Colorado. Thank you to everyone who's here in person. Thank you to everyone who's here online. We're here tonight to talk about MS with Dr. Enrique Alvarez. I'm Kelsey Morrow. I'm the education manager for the Rocky Mountain MS Center. I would also like to thank the pharmaceutical companies who have provided support for this series. Thank you to Bristol Myers Squibb and Genentech. This speaker series is just one piece of our education programming. We have a variety of formats available to you, including both in-person and online options. Most of our programs are also available on demand on our YouTube channel. Our most recent webinars covered MS basics and a cognitive functioning in MS. Coming up on March 28th, Dr. Molly Molman will discuss the why behind MS, genetics and environmental factors. And our next education summit will be a hybrid event with the option to attend in person at Anschutz in Aurora or online on Zoom. And we'll be discussing topics like treatment philosophy, stem cells in MS, other research updates, and spasticity. We do announce all of our educational opportunities through our mailing list and our Facebook page, and you can sign up for notifications through Eventbrite. All of our education programs are free of charge to anyone interested. And now I'll introduce you to Dr. Enrique Alvarez. Dr. Alvarez is the Vice Chair for Clinical Research at the Rocky Mountain MS Center at the University of Colorado. He's a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center in 2013. We did have a lot of great questions submitted at registration. We're going to get to as many questions as we can tonight. We'll start with questions in the room and then move on to the questions from registration. So again, you can raise your hand, you can enter them in the chat box. And just a note that tonight's presentation is for informational purposes only. All decisions regarding MS treatment should be discussed with your neurologist. With that, I'll turn it over to Dr. Alvarez.
Awesome. Thanks, guys, for coming out tonight. So the format for this is really informal. Basically, ready, set, go. Now it's your turn. So you guys get to ask questions, and I get to try and answer them. And so it goes pretty easy. Otherwise, as Kelsey knows, I can talk for an hour and a half without any questions. So that's not a problem at all. But let's open it up a little bit. Anything, burning questions? There we go.
So, hold on, let's get the mic.
So I have a friend who's in the throes of dementia, doesn't have MS, but I understand that, and I have a sister with Parkinson's, and their dementia does venture over into Parkinson's. What's a connection between dementia, or is there, and MS?
Yeah, so dementia just being an umbrella term for kind of say memory problems. And a lot of diseases that affect the brain will affect memory and can result in memory problems. The process that drives a lot of these things, are very different. And so sometimes they might be connected by the disease process, but a lot of times they're unfortunately just not. It's just kind of the end result. It's kind of saying like, I'm weak on my right leg, and it could be, a stroke, or it could be a problem in the spinal cord, like a slipped disc, or a pinched nerve, or other problems like that. And so it's a little bit of trying then to kind of break down the type of memory problem. So this is getting into areas that I try not to be an expert on. But for memory, there's like trying to remember numbers, faces, trying to process things. And so one of the pieces of memory that gets really affected in MS is more the processing speed. So like how fast you can work through something. If you think about things just kind of slowing down in MS, it kind of makes sense. And I sometimes call it the squirrel effect. If the things are just taking a little bit too long, it's a little bit easier for it to kind of go off into no man's land. And so a lot of times like word finding issues and things like that are part of that as well. That's kind of the memory that you tend to see, or the type of issues that you tend to see when you get the white matter, the connections part of the brain. And so things like a lot of mini strokes kind of affecting different parts of the brain can kind of also result in that part of memory being affected. Alzheimer's, which is probably the big one that we think about as far as memory problems, tends to affect more something called executive function, which is planning out like, okay, I'm going to change the oil in a car. What's the process for doing that? Okay, I need to go out and buy this stuff, and then I'm going to do this, and then this, and I got enough time. I shouldn't probably start to do this before, I have something somewhere else to be, and that kind of stuff.
So the delineation isn't just real clear. It's MS or it's.
Yeah, exactly. The delineation around the how to separate between this isn't very clear. And so cognitive testing is one of the things that sometimes we do talk about or think about. There's we can torture people in many different ways, and I think one of the worst one is sometimes cognitive testing. It's gotten a little bit easier for MS patients. They kind of simplify the battery. But some of the cognitive testing sometimes was like a day and a half, 2 days long of just like mental problems, and exercises and things like this. It's down to about still 2 hours. And it includes certain tests that I've seen adult people cry over, leave clinical trials over, just because they're really hard. One of them might have been me. One of them is like a PASAT test, which I think is probably the most hated test that I can think of as far as this stuff goes, where it's a video, like an audio recording, and it just reads numbers. And there's a PASAT 2, a PASAT 3, so every 2 seconds, every 3 seconds, they'll read out a number. And you're just supposed to add the last 2 numbers. But you have to keep in your head which one was the last one, and as you forget it, and try to keep adding the new one to it. I'll tell you my secret, but then I'll mess up a bunch of testing that happens, so I won't. But let's just say I'm pretty good at getting 50% of the problems right. So it's one of those things that it's hard. It's gone to some of the other testing now is a little bit more like the keyword findings, the SDMT or single digit modality testing. It basically has the symbols and then numbers or letters, I forget, and you have like a decoder ring, and so like then you just have to try and match up and kind of attach numbers. It's how many can you do. So it's a little bit more like a game, and so that one's gotten a little bit friendlier. So it's just trying to figure out ways to do that. It can be sometimes helpful, like at diagnosis time, where you're trying to figure out if is this Alzheimer's, or is Alzheimer's adding to MS or things like this. It also puts the same test at multiple times. So it tests a little bit like how much you can kind of wear out, how frustrated you get, like anxiety wise. And so it can kind of test mood things out a little bit as well. So sometimes, if you're very depressed, you're not going to think very well. If you're tired, you're not going to think very well, remember well. And so it can kind of give you clues as to what's affecting the memory piece. That's probably more than you wanted to know, but anyway, yeah.
How close is research to finding out where the MS comes from, whether it's a virus or what is?
Yeah.
causing-
So yeah, the question is, how close are we to figuring out the riddle of MS? I mean, I always kind of say it's around the corner. It's just coming around. Been saying that for a couple of years now. So I think we keep getting clues about this. I think it's not going to be a simple answer to say it's this one thing that's causing MS. I think it's going to be a lot of things kind of having to merge up for certain people that will give us a clue as to what comes from MS. To the point that sometimes I think about MS even as 2 diseases, relapses and progression, but at least, the relapses I think are the initial part of it. And there's a disease, we call it ADEM for short, because the long term is really hard to pronounce. But that one disease we can sometimes see it after like a virus infection. And sometimes MS can kind of, when it starts, look like that a little bit and become a little bit more MSC-like when we look at MRIs and things like this. So it's a little bit of a clue that sometimes maybe there's a virus or a bacteria or some infection that kind of precipitates the process. And you might have heard over the last couple of years, there's been a lot of excitement about Epstein-Barr virus being sort of that trigger point for it. opinions are a dime a dozen. My personal belief is it's probably not just one virus. I think it's just an insult that happens. The Epstein-Barr viruses are all, sorry, not the herpes viruses, of which Epstein-Barr is a type of virus in that family, which includes shingles, herpes like type 1, the oral genital herpes, and several others. Cytomegalovirus or CMV is another one in that group. To the extent that sometimes antibodies against one of those viruses recognizes other viruses. So you'll see a lot of like, oh, the antibodies against Epstein-Barr virus were found in this. They probably also bind some of the other ones if they got looked at. And so, so as far as that part of it, it looks like maybe that's the starter. Then you need to have sort of the wrong set of genes. There's been over 200 plus genes associated with MS. Most of them contribute like that much to it. So you probably need to have the wrong 30 or 40 different genes associated with MS. Most of those genes are involved in the immune system, so are kind of like our ability to fight things. The one that stands out is what we call the MHC molecule, a major histocompatibility complex. And it's basically when a virus comes in, a cell kind of has to recognize, hey, like this isn't me, or it is me. But if it's not me, I got to try and get the immune system kind of started. So you have, when it's a foreign something, we call it antigen. So that cell has to present, we say, the antigen to other cells. And so sometimes like some of the cells in skin and other things like this in the gut are good at chopping up that virus and putting little pieces out and presenting that. The spoiler alert a little bit is one of the cells that does that is the B cells. And so even though we've associated B cells to be primarily the cells that then become plasma cells and make antibodies, and they got implicated in MS because you see all these antibodies and spinal fluid, like people that get spinal taps, that's what we're looking for, is making those antibodies. And so they started targeting those B cells because of that. It probably has to do because they're actually presenting those foreign things to other cells. And a lot of the other genes associated are with kind of then that ramp up of the immune system associated with that. So the immune system probably then has to be in such a way that we need to kind of activate the immune system to be able to fight that virus. And then it just gets confused. Instead of going away when the virus or bacteria goes away, it just kind of keeps going and it causes this disease. There's a very cool series of papers that I understood about that much of, that they looked at a bunch of skeletons of people that were migrating through Europe. And a lot of the genes associated with MS were genes that sort of developed through these migrations. And you ended up with kind of the Northern European set of genes that have really been much more associated with MS, and probably had to do with increasing our immune system so that we could fight bugs. So think like plague and, you know, all these things, TB and stuff like that, that, you know, affected us early on as human beings, to be able to say like, hey, we don't want to die from, you know, the plague. We might take a risk of getting too much of an active immune system. And so if we get MS, that's okay. You got to think most people died in their 20s, right? So like the life expectancy to develop MS was not a big thing. You didn't want to die when you were 4 or 5 from TB or other things like that.
Environment, what effect does the environment have on all of that?
Beautiful.
MS is known to be occurring more in cooler areas.
Yeah.
Colorado.
Yeah. So then the environment plays a role within probably changing that, again, possibly immune system, right? So one of the some of the factors associated with that are vitamin D, which you know, we make from sunlight. The other place that you can get vitamin D is eating liver. And we're always curious to see how many people still eat liver. All right. Yes, less than maybe 0.25% of the people here. So like very few people will eat liver on a regular basis. So you need the sunlight, and most of the people are still really low on vitamin D for that reason. So that's why we need to supplement it a lot of times. Vitamin D actually triggers some of those genes that I was talking about that are associated with MS to go up or down. They actually drive how much of those genes get expressed. So that's probably a little bit of how the environment affects the immune system to kind of make everything kind of come together and increase that chance of developing MS. Things like smoking increase inflammation, so they just ramp up the immune system. Obesity probably does the same thing. So these other things that probably increase the risk of MS a little bit. And then I always say, you know, and if it's a blue moon, because there's a lot of stuff we don't know that probably plays a role in all this stuff. And so that's why we say genes, environment, exposures, all this other stuff become really important for this.
I wanted to ask if you think barometric pressure changes affect people with MS more so than the next door neighbor that doesn't have the MS situation.
Yeah, I mean, barometric pressure is always kind of an interesting one. I mean, we'll hear it a little bit from MS. We also hear it a lot from arthritis patients and things like this. So I think these are the things that when your body doesn't have a lot of buffer to it, you know, to kind of deal with the environment and the things around us, where it gets a little bit, it takes less to kind of bring out stuff. And so, you know, you hear a little bit more about some of that affecting MS patients who are a little bit more disabled, the arthritis patients who tend to have worse disease in their hands and things like that. So I think it has to do a little bit more with those kinds of things than something specifically affecting the immune system or other things like this. I mean, this is where I can, oh, we got one other question. All right.
A little bit about, oh, thank you. Would you talk a little bit about younger people getting MS,
Yeah,
children, babies?
I can talk quite a bit about that. So, so the question around, you know, age effects maybe on MS, we can kind of broaden the question out a little bit, but especially with kids. So there's been reports of babies less than a year developing MS, pretty rare. And when you look at the risk between sort of men and women, that risk is actually about a 1-to-1 up until you hit puberty. And then it starts to kind of shoot up a little bit on the risk. So I think it's like 5 to 10% of people get diagnosed under the age of 18. So it's a small percentage of patients with MS. The peak of getting diagnosed with MS is roughly around 30, 35. And then, you know, it kind of seems to kind of die out a little bit later on as far as the chances of developing MS. Where that gets tricky, right, is stuff continues to happen that might sometimes lead to an MRI and getting diagnosed later on. But the number of attacks really happen, is much more likely to be severe early on in younger patients. The immune system is just that much stronger in kids than it is in somebody who's in their 70s and 80s. And so a lot of times from a treatment perspective, we really push those early high aggressive treatments early because we're trying to kind of fight that stronger immune system. As you get into the older ages, you know, we start to kind of back off a little bit because that's where you start to have, you know, your immune system isn't as good. So you start being more at risk of the flu and, you know, all the other infections, COVID, as we learned about it. And so as those infections kind of ramp up, we don't want to lower the immune system as much, and we don't need to because the immune system just with age is kind of dying off a little bit.
On the subject of children and getting MS, what are the chances of children having MS if their mother or their maternal grandmother has it?
Oh, great question. Yeah. So just because I like simple numbers, so I tend to use multiples of 10. So if we said the chances of developing MS is about 1 in 1,000, a first degree relative, so kids, sisters, parents, not so much because of the age thing, they would be at a 10-fold higher risk of developing MS. It still puts it at about 1% chance of developing MS. So it's a still relatively low risk. Those numbers kind of creep up a little bit. So instead of like 1 in 1,000, we might say 1 in 500, 1 in 400. So you might say it might be 2 or 3%, you know, chance of developing MS.
The only way to really consider that to be tested in an MRI of your offspring.
So our best way to try and detect it in offspring is probably an MRI at this point. 90 to 95% of brain lesions don't give you symptoms. And so the chances when you do the math a little bit is that the person to develop that first symptom with a lesion probably already has like 12 to 16 lesions before that's recognized. Part of this, just to put a plug in, is one of the studies that we are doing. There's two, DREAMS and RISE. DREAMS is for kiddos from age 10 to 18, and then RISE does, 10 to 17, and then 18 to 30 goes through RISE to look at first-degree relatives of patients with MS. If you're interested, there's propaganda up here with information to contact for that. It's a quick screen. It basically is just an MRI. And what we're finding out is that there's a number of people that we're identifying that have an MRI with a couple of lesions that look MS-like. And 2 patients so far in that study, I think with 150 to 200 patients that we've screened so far, have gone on over the next couple of years to develop MS. So we're trying to kind of get blood and other things like this so that, you know, if someday we develop a good biomarker, we can kind of look at those things. And so we're looking at those things at this time. But
Sticking with the theme of children, can you talk a little bit about pregnancy and the anti-CD20 medications?
yes. In the past, a lot of times because our treatments kind of sucked, we would often tell women not to get pregnant because that way we didn't have to stop treatment. Or if we didn't have treatment, it was always a concern. And part of that is around pregnancy, just to talk about the risk, is that you see that the amount of risk, if you kind of say it's about this much, over pregnancy, it kind of goes down. By the time you deliver, the risk is about half of what we normally would expect. So sometimes you would hear MS is a cure for, pregnancy is a cure for MS. The problem a little bit is that after you deliver, the 2-3 months later, that risk starts to kind of go up, and it goes up about twice the risk that normally is there. And so a lot of times we want to make sure that those drugs are kind of in place and covering you for that bump afterwards. And a lot of women, unfortunately, develop their first symptoms kind of after pregnancy. And so it's just important to kind of be aware of that kind of bump. With CD20s, one of the things that we started to try 7-8 years ago was we knew from one of the early studies with rituximab, which is not approved for MS, but we can use here in Colorado a lot of times under certain insurances, that they did just a single cluster of doses, because the way they did it is the course was like 1 gram, and then 2 weeks later another gram, but it's really one course or one treatment if you want to think about it that way. And they did nothing for a year. And so what they saw is that really the number of attacks really flattened out for that entire year. And it's probably a little bit longer than that. And so we said, well, 9 months fits into that 12-month period really nicely. And so it's, can we do, you know, those treatments and then kind of watch over, you know, the period of the pregnancy. So we started doing that, and it actually worked out pretty well. And then mom started to ask, well, what about, you know, can I breastfeed? What do I do after I deliver? And so that was something else we had to start kind of thinking about through. Initially, I think there was a lot of concern. So we said, you know, no breastfeeding and stuff like this. We started kind of realizing, getting some data, is that the levels of those antibodies do make it into breast milk a little bit. But after a certain period of time, any of the proteins that make it into breast milk would be like any other protein that would be in a meal that a kid would have. It would just chew it up. And so the first couple of weeks, the baby can absorb a lot of that stuff, and that's the colostrum milk. The stomach hasn't become acidified, and so it can't chew up those proteins quite as well. After 2 weeks, and you know, sometimes I'll go up to 3 weeks just for good measure, you know, we say, hey, go ahead and start getting your treatments. And so far we've looked at then the B cells in babies and been able to see that those babies have really normal levels of B cells. And so this was stuff that we've kind of done a little bit. We're up to like, I think 12 kiddos now that we've looked at in this. And Anna Shaw in particular has an interest. She's one of the other docs in our center, and she's now looking at the outcomes for pregnancy. And I think we've had like over 200 pregnancies at this point under B cell depletion. So far it's looking really good outcomes.
Is there any correlation between B-cell lymphoma and MS?
I mean, besides the fact that they affect the B cells and, we use some of these drugs for both, we have not necessarily seen a correlation or anything else like that with it. We have made some diagnosis of B cell lymphomas in our MS patients, but we have about 4,000 patients. So you kind of expect that, we would see some of these connections happen as well.
And then I had this issue happen, so then I'm thinking.
Could that be associated? Yeah. I mean, so far it looks like it's kind of true and unrelated. And whether the B cell depletion unmax some of these conditions and things like this, we worry about a little bit. For people that know a lot about B cell stuff, there's always a concern about breast cancer with Ocrevus. In the clinical trials, there was a number of cases that were seen. The challenge with that is, again, when you look at the trial, it was 3/4 women under the age of 55. So if you're going to see a cancer, it's breast cancer. And as we followed those patients, we haven't seen that there's an increased risk. And that was kind of in the range of what we normally would expect. That's been the biggest signal we've seen, and we've not seen it with the other B cell depleting therapies. So I think the thought is it was probably just, you keep looking for all these things, you're going to find something. And you just have to see how consistent, that signal is.
What causes Dawson's fingers on MRIs, and what do they mean?
Awesome. So Dawson's fingers, so in the old days, right, if you saw something and described it the first time, you got it named after you. It was kind of like, a nice little prize, and you became infamous. Hopefully you didn't do anything bad, because then they got to change the names, right? So Dawson described that the lesions in MS are somewhat egg-shaped. So inside the brain, there's like two C-shaped structures that kind of sit opposite of each other, where you make spinal fluid. And feeding into those C shapes, so like you got two C shapes like this, are a bunch of blood vessels that kind of feed into it this way. The lesions kind of sit kind of pointing away from that C shape. And what we found in pathology early was that there's a little vein that kind of pops in through that. So we call it a central vein. And one of the cool things was on MRI, now we can kind of superimpose MRI sequences that look at blood vessels along with the lesions that look at the scars in MS and see if there's a little vessel along that lesion. We call it the central vein sign. Different studies are proposing different cutoffs, but it looks like that's pretty specific to MS. Later on this year, we're going to get a new update on the criteria for MS. So probably the 2023, because actually they met in Barcelona in December, but it'll come out later this year, where they're probably going to add that central vein to the diagnosis of MS. And so it's looking at MRI at those lesions and trying to kind of say if you have a certain number of those, then it meets another criteria for MS.
Are there specific places in the brain and spine where MRI tends to show lesions, or can you link specific symptoms to lesions in certain areas?
All right, so I'll take the first one of that. There's certain places we already talked about, around the ventricles, those lesions that have the Dawson's fingers or the egg shape to them. The other place is, if you look at a picture of the brain, it looks like a raisin, right? It's all shrivelly. And so the bottom of those grooves, sometimes you'll see these C-shaped cups. That's a very classic MS-looking type lesion. We think that sometimes some of the inflammation kind of sits on the surface of the brain, and in those pockets, it doesn't get washed out as much. So a lot of the chemicals that they might produce might be toxic and kind of produce some of those lesions. We see them in the back of the brain. That's our third area that we think about as far as MS goes. not sure what necessarily leads to that, but sometimes you'll see little veins on those, and sometimes you'll see them on the surface of the brain as well for that. And then in the spinal cord, you'll also see some lesions there as well. In MS, they tend to be more in the neck, and they tend to be in the lower part of the spine. But legs tend to get primarily, much more affected usually than hands, because those nerves are that much longer. So there's a bigger chance of them having a lesion that affects them over time. So those are the 4 areas. And with those new criteria, the 5th area might be the optic nerve. For some reason, we've known about optic neuritis and MS being associated for a really long time. And for some reason, we've ignored it, for hundreds of years later, after we described MS. So not sure why, but I think it's going to get its due and get added in here by the end of the year. So that was kind of where the lesions are and memory problems. I forget what the second part was.
I think you covered that whole one. Does MS affect sleep? And if so, how can it be treated?
Yes, definitely MS can affect sleep. A lot of times much more indirectly than directly. The centers that control sleep are usually not hit primarily by MS, but to sleep well, you can't have restless legs, you can't have pain, you can't get up in the middle of the night and go pee and have good sleep. And so there's a lot of other things that tend to affect that sleep component to it. And so I would say it's pretty common early on when you don't have a lot of disability. You're still, obviously very anxious about the diagnosis and kind of seeing where things are and that kind of stuff. So anxiety, depression, all those things kind of really can kind of contribute and affect sleep as well. With time, as you develop MS and just as we get older, a lot of times, we like to put on some weight, and that, leads to apnea issues and things like this. And so we start to see, especially in MS patients that have mobility issues, much more problem with kind of gaining weight. And then with that, much more issues with sleep apnea and things like that. So a lot of things that, secondarily get affected by MS that can kind of lead to having sleep issues.
Just wait for the mic, please.
So related to sleep apnea, and most apnea, I think, is physical due to weight gain or what have you. But then there's also a condition known as central sleep apnea. How does that affect an MS patient? And what can be done besides just a machine?
Unfortunately, it's just the machine. So the central apnea is central being kind of central nervous system, so much more brain control than sort of a lot of the other apnea, which, is just kind of throat closing up and things like this issues. I'm not aware of any other specific treatments for that kind of apnea besides, again, CPAP and a lot of the other machines, just to kind of get that breathing kind of set up. It usually, my understanding is it gets a little bit harder to control, but you can kind of work on it with the machine, and the machines can kind of help. A lot of times it's whether, how much is the machine versus the oxygen and all that kind of stuff, but you can kind of force some of those things at least to kind of help prevent those dips in oxygen.
Would you recommend a COVID booster if you are on an MS-DMT? And while we're on the subject of COVID, do you have any other thoughts?
Thought we were done with COVID. All right. So COVID. I think it's hard to answer that question because I think the spectrum runs so wide for a lot of our patients, depending on what treatment you're on, age, level of disability, and all those things. So I'm going to kind of just talk about infections maybe more broadly and kind of talk about sort of the risks associated with them. And then that might help kind of stratify to kind of say sort of how much about the vaccine and where to do that. So we talked a little bit about the risk of attacks going down with age, that the immune system goes down with age. So as you get older, the risk of having worse outcomes as you get older is true. We see that. There were a lot of studies from COVID in MS patients with like tens of thousands of patients that kind of allowed us to kind of try and identify those factors that were associated with kind of worse outcomes. So age was there. You had risk factors such as, we heard a lot about comorbidities, so high blood pressure. Diabetes was kind of a big one. I think high cholesterol was kind of a smaller, heart disease, lung disease, asthma, things like this. I mean, some of those kind of make sense, to some degree. When you look at the risk of maybe dying, if you had any one of those risk factors, it was maybe a twofold higher risk, right? So you start at a pretty low risk, you have any one of those and you just kind of maybe double that risk, right? So if you look at hospitalizations, ICU stays and things like this, they're all kind of in that same range of twofold higher. The drugs, for the most part, and the B-cell depleting ones were probably some of the worst ones. The other ones were like Gilenya type drugs, so the S1P inhibitors. They didn't increase death, they increased the risk of getting hospitalized and things like this. And again, they were in that same range of twofold. So it wasn't like a huge risk associated with that. The big factor that jumped out, especially for COVID, was being in a wheelchair. And that jumped up the risk 25 times. So that was 10 times higher than the risk from any of the other risk factors associated with that. And why is that? Because a lot of times being in a wheelchair meant that you don't empty your bladder very well. So as far as urinary tract infections, if you have breathing issue, you're kind of having issues kind of swallowing and things like this, then it becomes hard, you're more likely to aspirate, you don't clear, the virus as well, and some of those other things, right? So the less disabled, the younger you are, the less the risk, the more comorbidities, the, more disabled, that kind of stuff, the higher the risk. So I recommend it for this group a lot more to get a lot more vaccines. To the other group, I worry a little bit less about it. You might say, this is different from when you told us like 3 years ago. The caveat now is we got some vaccines, people have been exposed. All of us probably have had COVID 2 or 3 times. If you had a couple of shots, all those things boosted up your immune system. The reason for maybe pushing them now a little bit less is the COVID vaccine is probably one of the strongest vaccines we've had. And so the virus changed a lot early, but it's not changing a ton now. So I don't know that necessarily you need to do this like every 6 months or every year to kind of keep up with the virus. That's about the same. So my general rule of thumb is like, if it's been 2-3 years since you got a shot, since you had COVID, I would, you're in that higher risk bucket, I would do it. If you're kind of on the younger side, you've done well with it in the past, the virus doesn't change because it could change at any time, right? In that case, I don't know that I would potentially keep spreading it out and waiting until seeing what happens a little bit. So that's a little bit, specific to COVID, but a little bit around some of the other things. So the other vaccines, right? I would prioritize, for example, the shingles vaccines. The B-cell depleting drugs, the S1P drugs are associated with increasing the risk of shingles by about 2-fold. So that would be one. If you've had shingles once or twice, I would probably consider getting the shingles vaccine. The flu is a very crappy vaccine, and that changes every year. So that's the reason for doing that on a year in, year out basis. I think it's important from a vaccine perspective to recognize that we call it a success if you don't die from the vaccine. It doesn't mean that you won't get the disease. I think that's an important point because it's like, it didn't work for me. I still got sick. You didn't die from it. So just putting it in perspective a little bit about it. The problem with the strong vaccines is they kind of make you feel like you're dead for a day or two. I mean, they're really strong and they really kick up your immune system, and that's the problem. So taking some ibuprofen to kind of keep the fevers down, tolerating it better, I would recommend a lot of that stuff just to kind of make it through the process a little bit better. Sorry, I think I went on like 2 or 3 tangents on that one, but yeah.
Neurologist took me off of the medications that I was on after I reached a certain age, and it seemed to be doing okay with that. But is that typical for MS people to get off their medications, MS medications, after, say, 65 or 70 or something like that?
And
Tip-
can
yeah, I'll
you
review it.
also include the natural history? We had a couple questions submitted
Okay,
online.
perfect, yes. So the question was around coming off of drug around 65 or 70, and kind of what's the natural history of MS. So I alluded to that the number of attacks goes down with age. We were part of Dr. Corboy at our center led a study called the Disco MS, the Discontinuation. He wasn't a disco dancer, I don't think, but he showed that there was a pretty good chance that you would do really, really well if you stopped treatment. And he looked at people that were 55 or older who had been stable for 5 years clinically, 3 years on MRI. The one person that had MRI activity with a clinical relapse was 55. And there was a couple of other people that had MRI activity kind of past that. So I think, and a lot of those patients were on kind of what we call the platform drugs, otherwise known as the crappy injections that we used to have initially, you know, the interferons, the copaxones, and those kind of meds. And so from an efficacy perspective, you know, if you're starting here, mid-efficacy with some of the pills and then, you know, the injections down here to off, this is a little bit of a safer jump. So when, you know, do you cut it, you know, do you go from the infusions at 55 to stop altogether? You know, how do you do that transition is something that we're doing a lot of work on now and looking at sort of de-escalation, because so much more of our patients now are on those B-cell depleting therapies, not so much of those injections anymore. And so kind of thinking like, do we do some step downs? Can we do that a little bit earlier? When we look at those infusions, and particularly we look at rituximab and Tisabri compared to Gilenya and Tecfidera, so two of the mid-tier drugs, we saw that early on where there's a big difference in the immune system, that we could see big difference between the drug types. But as you got older, that difference kind of went away. And by the time in our center, about the time you were about 54 to 55, that difference really disappeared, so that the high efficacy therapies were no longer high efficacy because there wasn't much of a difference. We don't have enough people on those lower tier drugs now anymore to kind of go back and look at those lower tier drugs to kind of make comments about, you know, how and what that would look like. I think the other piece to that, though, is recognizing, and sometimes we forget about this, that, you know, MS for some people is very different from MS in other people. You know, you look across the room and it looks very different, right? Some people get disabled from that first attack, and some people will do really well. Some people never become progressive. Some people become progressive from the get-go, and those kinds of things. And so just kind of like that, we got people that get diagnosed with MS when they're months old. There's people that don't get diagnosed with MS until they're like 65 years old. And so taking a 65-year-old and say, we're not going to put you on treatment because you're 65 and old, you clearly just broke through, you had an attack that led to the diagnosis. So I think you have to look at it a little bit, not just by age, and saying like, how long have you been stable? Have you been stable for at least, I like 5 years, at 10 if I can get it, before kind of thinking about taking a step down or stopping treatment. You know, a little bit more leeway, I think, the older you are. I mean, I think that's where it gets really hard to come with those hard rules. And you kind of have to kind of say like, you know, did you bounce back from your attacks well? Did you have a lot of attacks? Did you have very aggressive disease? And those kinds of things to kind of make those determinations. So at some point, yes, I think you can get off of those medications. The part that gets hard as well is, when we think about disease, you might be on it from a relapse perspective, you might be on it from a progressive perspective. And so from a relapse perspective, to end up on those oral medications, you know, is fine sometimes as you get older patients. But sometimes you end up kind of then bumping them up to the B-cell depletings, because some of those medicines are the ones that have a little bit more data around progression of MS. And so as you know, as you get older, there's more chance to be progressive. And so sometimes you end up kind of making this decision of like, B-cell depleting infusion or nothing. And that is a really weird position sometimes to be in, of like, we're going to go for maybe a potential side, you know, a tiny little effect with a big gun, or are we going to hold off and not do anything? And so you have to kind of weigh that. And sometimes I think it's kind of like doing it with a purpose and saying like, hey, we'll do it, but let's do it for like 2 years. We'll see what that happens, see if it slows anything down. And if not, then we're going to stop it. And so you have sort of a little bit of a timeline as to kind of where I'm going to go with that treatment decision. And it's helpful to make that up front sometimes, because otherwise you're like, oh, let's just try it another 6 months. And then it gets that much harder to kind of pull the trigger on it.
Can we go back to vaccines for just a moment and talk about the RSV vaccine?
Yeah, sure. Ask me about the new one that I know very little about. So RSV is a newer vaccine. RSV is associated with a lot of asthma. And so I think it's an important vaccine because it can lead to a lot of bronchitis, asthma attacks, and things like this. We tend to think about it as mostly a kid's virus. You know, kids will get RSV, they get knocked down for a few, you know, days, and it's no big deal. But a lot of times when we start to get it, you know, it knocks us down for weeks to months. And I think that RSV was one of those viruses that, as the pandemic was kind of coming off, you know, its last throes, and people were unmasking and stuff like this, people were getting really sick because all of a sudden, not only were they getting COVID, but if they actually got tested, a lot of times it was like COVID plus flu or COVID plus RSV, all three. You know, it was like everything was just traveling in packs because we hadn't seen it, our immune systems were challenging and that kind of stuff. So I personally recommend the RSV one because on the kids side, it's so common to see the asthma effects from it. My daughter gets asthma, and especially after RSV, she occasionally, whenever she gets an upper respiratory infection, she needs a little bit of an inhaler. She does fine with it, but I think it's hit a little bit too close to home to kind of say like, hey, let's avoid this one. And I think it's kind of bad enough, and it's hard to control some of that reactive airways that kind of goes with it. So I like it for that reason.
Can you speak to cerebellar atrophy and MS, and how often does it seem, or does it seem more prevalent than cortical atrophy?
It's a very specific question. So atrophy is just shrinkage. And, you know, sort of news alert, after the age of 30, 35, all our brains are shrinking. So we're all headed in the same direction. Certain parts of the brain shrink more than other parts. So sometimes it might just be because it's easier to measure, but some of the work out of University of Southern California by a good friend, Christina Azevedo, showed, for example, that in normal aging, certain parts of the brain called like the caudate, putamen, so areas sometimes associated with like Parkinson's, as you get older, those tend to shrink a little bit more. In MS, we tend to get a little bit more of another area called the thalamus. And so sometimes in trials, you'll see thalamic atrophy being measured. Measuring cortical atrophy is really, really hard because it's kind of like trying to dissect out the skin of a raisin. And that's what they're trying to do to measure all this stuff, is literally take that little ribbon at the surface of the brain and try to measure how thick that is. It's a lot of time of somebody clicking through pictures and highlighting little areas. So how well do we do that? I think is really hard. And I'm not sure we're measuring it really well to be able to answer that question exactly. But cerebellar atrophy, when they're asking about it, it makes me nervous because sometimes with cerebellar atrophy, there are the classic, what we call paraneoplastic antibodies. So these are antibodies that sometimes when you have a tumor and your body gets a little bit confused, but part of the immune system is to try and fight cancer and tumors and that kind of stuff as well, is that it will get a little bit distracted and start making antibodies to stuff that tumor makes. And so the classical ones tended to cause a picture of cerebellar atrophy. And they have very exciting names like anti-yo, Q, some of these TR, you know, some of these, they stand for people's names who describe these antibodies. And so You can see that associated with that. Some of the newer antibodies will do that. And so cerebellum kind of controls coordination. And so these are patients that gradually develop much more of a progressive incoordination. Think drunk. They just look more and more drunk. Their speech gets slurred. You know, they walk very wide based. They go reach for something and they're kind of like going like this because they can't target very well and things like that. And so those are some of the other diseases that we also treat, but those tend to be like 1 in a million, so we don't see a lot of those. But Amanda Piquet at our center specializes in a lot of those other autoimmune conditions. And we're learning about 2 to 3 new antibodies a year. So I'm glad she's interested in that because I can't keep up anymore. So.
Can you give an update on the BTK inhibitors as well as any other new MS drugs that are in the pipeline?
Somebody wanted to hurt my feelings. All right. So we were very excited about BTK inhibitors. We're still kind of excited about BTK inhibitors. The first one just reported out results. We got the top line results of the big clinical trials for it. The drug was called evobrutinib. Idenib is kind of the last name of a lot of these drugs. And we just kind of heard more of the full data about less than a month ago at kind of the US North American MS meeting. And it didn't look good at all. So that one's probably dead. This summer, we're likely to hear about the second one called tolebrutinib. Tolebrutinib will give us a little bit better idea because the excitement around BTK inhibitors is that they might have an effect on progressive disease because they're small molecules that can make it into the brain. And so some of that immune system that's making those bands, again, that we look at in spinal fluid might be something we could reach with these drugs. And they actually have studies that are relapsing studies and studies that are progressive studies. And so I think if it does something maybe on progression, but not relapses, relapses tend to cause a lot more disability. So it's really hard to study progression if you don't take care of relapses. And so that's the challenge. And so I think this one will give us a better window, but there are literally like 6 other ones coming behind that one. Fenebrutinib is the next one, Remyelination after that, and then a bunch of other ones that I can't remember the names of after. But.
Are there any other drugs in the pipeline?
Yes, there's a lot of drugs in the pipeline. The next cluster that I can think of and know of is frexalimab. That one is starting the big phase 3 trials, and it's something that targets more T cells through instead of being a CD20, these are CD40 ligands. So the antibody that actually binds the CD40. So this is an antibody to the antibody that recognizes CD40. We've been interested in that molecule a lot because there's a researcher on campus that studies CD40 cells. And early on, we associated it with patients that were relapsing, but curiously, there were much higher levels of those cells in patients that were progressive. And so they're doing a progressive trial in a relapsing study. If we're starting the phase 3 trials, think 3, maybe 4 years before we get the results of that. From a remyelinating perspective, we heard a little bit more data on clemastine, which is a small molecule. It was kind of plus minus in MS patients, small benefits that probably patients wouldn't be aware of, on some of the testing, like, these tiny, we talk about it like in blood pressure terms, the blood pressure medicine that sometimes maybe drops your blood pressure by like 2 points. Yes, maybe it does decrease your blood pressure, but that's not going to prevent that heart attack or stroke or anything else like that from it. And so, so that's still being looked at. There's trials ongoing for like alpha lipoic acid, and things like this. It's always interesting because these are things that, you know, you can buy over the counter, but like the alpha lipoic acid, this is the warning around these trials, right? Alpha lipoic acid actually got stopped for a while because there were some liver issues associated with it, whether it was the alpha lipoic acid or the fact that it was in liver, like in oil capsules, and the liver kind of gave, the oil affected the liver. It's hard to know. We see that sometimes with like the cannabis trials where like, because it's fat soluble, they package it in oil, and sometimes just it's too much oil for bodies that aren't used to dealing with that, and it can affect the liver, and it's sometimes more the other drug that kind of you need to get the actual drug. So that's part of the reason we do these studies, because sometimes we just don't know. There's several other things that are being looked at. It's just how far along the lines they are. There's something that's an electric stimulator kind of a thing that sits on the vagus nerves that they think might help do this. And in mice, it looks very promising. You know, this kind of stuff. So it's a challenge that way. The other big cluster of drugs that I think people are very excited about, surprised it hasn't come up yet, are stem cells. So stem cells come in many shapes and flavors. So you can have, you know, sort of the gold standard, I would say, is the full bone marrow transplant, where you take your immune system out completely and replace it with one that doesn't like to give you MS, for example. That theoretically is a cure for MS. The challenge with that one is taking out your immune system is associated with killing about 1% of people that go through it. And so it's, you know, risky in and of itself. How much of those stem cells actually can identify the cells that are broken and try to replace them and form all the right connections and that kind of stuff from a repair perspective is the part that at this point we'll still try to kind of really sort out and figure out. There's kind of stem cell light stuff where they take other people's immune system cells and put them back into you without necessarily killing all of your immune system. So they'll give you some chemo type products, and how much that chemo is the differences between how different centers do it. And then they put these cells in. There's a center in Mexico that does that. They've reported on over 1,000 patients, and they do really pretty well from a relapse perspective. The problem is, it's not a problem, it's a great thing, but they give you chemo, they do that, and then they give you rituximab. And I'm not sure how much you needed the stem cells of the chemo on top of the rituximab to end up with those great results from a relapse perspective. And so that's the part that it gets hard to kind of tease out, and what part of the treatment's actually helpful. Then they got stuff where they can take your own cells, and as long as they keep them outside of you for less than 24 hours, they can do whatever they want and put them back into you. If they take good care of the cells, you might get something. I've heard cases where sometimes the cells are just putting in dead cells back into you, you know, and that kind of stuff, and still charging you a few $1,000s for. So you see a big spectrum of things, and that's where I'm really hesitant for people to like do this in a place that's not through research, because it can charge you a lot of money for it without really learning about it and just kind of, you know, deepening their pockets a little bit with it. CAR Ts is another big cluster. I'm completely spacing out what the CAR part of it, but it stands for something against T cells. And basically these are T cells that recognize something. In MS, a big target has been CD19, which is similar to the CD20s. So you might say it's kind of similar to rituximab or Ocrevus or ublituximab or ofatumumab, these B-cell depleting therapies. One possible advantage of them is that they might make it across the blood-brain barrier into the brain and actually get into some of those cells that are kind of protected in the brain. How you do that varies, and there's several companies that are looking at how to do that. Again, they take them from you and they develop your own those cells from you, or they take them from somebody else and have a bank of cells that they can put into you and that kind of stuff. So there's a lot of things kind of being looked at for these things. So there's a ton of stuff that's being developed. it's just every year we hear about 2 or 3 new things, and we've ended up with 2 or 3 new drugs a year. We're starting to kind of get into a little bit of a dry spell, and these BTKs were supposed to be that next big thing. Maybe not. So we'll see. Yeah.
Well, this is so new for me. Today was just my second IVIG infusion.
Okay.
Could you explain a little bit about it and how soon I might hopefully notice a difference and if it's common with MS patients?
IVIG is not very common for MS. So IV just means intravenous. IG is immunoglobulins or antibodies. And there's different types of antibodies, G, A, M, these kinds of things. They all kind of do different things within the Gs, which is the main one, and that's usually the ones that are given. There's different types within that as well, 1s, 2, 3, 4s, anyway. So while they're doing things like collecting plasma or blood, they can isolate antibodies, collect that, and help boost your immune system. So we use IVIG and MS in a couple of different ways. We sometimes do that for people who are having relapses, so kind of those acute events. The data is maybe they're just as good as steroids, maybe a little bit better, but if the steroids aren't working, sometimes they try IVIG. Some people have tried to use it kind of for long-term chronic care of MS. There's not a lot of data for that piece of it. The other issue a little bit is you take out those B cells with a lot of those B cell depleting therapies. Those B cells are the cells that become plasma cells that make antibodies. So if you keep taking out the supply chain, eventually the levels of antibodies start to kind of dwindle. And that's kind of what we see, is that the levels of antibody drift down a little bit. Not super fast, but if you're on drugs, like this for like 20 years, 15 years, we have seen that those numbers get to the point where they can get really low. And so sometimes then you have to kind of give those IVIGs, those antibodies back so that you can kind of keep your immune system at a basic level of functioning. And so that's the one place where sometimes we use it. So.
Should I see a difference like soon or? Really?
From a relapse perspective, yes. I mean, usually it's like an acute treatment for that kind of stuff. If it's more for maintaining antibody levels, then you won't see a change because it's fixing part of the immune system, which hopefully you're not aware of it working, and that kind of stuff.
I have a complicated question with a lot to unpack. This person has had MS for 44 years. They believe they have spine lesions, but haven't had an MRI of their spine. So they have kind of a two-part question. What should they be asking of their neurologist as far as MRIs go, or checking up? And then the other half of the question is that they've been stable for over 10 years, but their walking is getting worse and they've had no treatment for MS.
Okay. We'll talk about progression and the need for spine MRIs. I think we'll split it that way. All right, so let's start with need for spine MRIs. So spine MRIs, I like to get them at baseline when we're making initial diagnosis, just to kind of see sort of like the extent of damage, like helping kind of nail down the diagnosis. Just because you have MS doesn't mean you don't have a slipped disc. Other things like this that could kind of contribute to disease. So it just kind of paints a picture to kind of know where you're at. I mentioned initially that 90 to 95% of brain lesions don't give you symptoms. So we're not monitoring the brain MRIs for stuff that gives you symptoms. If you come in and you say, hey, I lost strength in my right arm, we know that, probably, as long as it sounds like an MS attack, it starts kind of slow and builds up kind of like a bruised white, would, then, it's probably a relapse, and we could treat it with steroids and try either IVIG or something called plasmapheresis. The part that, kind of gets tricky is when you start to kind of say, how much does a spinal cord MRI add to that? So if you think about the brain MRI, usually it's about 30 minutes, maybe 20, 25 minutes. You add the spine, that's 2 extra MRIs. So cervical, thoracic. Sometimes you'll see people add the lumbar spine. From an MS perspective, no help at all, because there's no spine. That's why we can do a spinal tap really safely. The spinal cord ends up kind of where your ribs end. And so you're talking about doing 3 MRIs versus 1. So you went to an hour and a half versus 30 minutes, 3 times the cost. And does it give you 3 times as much information? The answer is no. There was a recent paper that the neck one, again, there's more neck stuff than just thoracic, added maybe 5% more information than just doing the brain MRI. So if MRIs were fast, cheap, easy, I would say yes, you should do the spine MRI all the time. But I think otherwise, I tend to reserve them unless you're fishing for either new symptoms or things like this. Or if you want to do them every 5 or 10 years, like spreading them out some, then I think it's fine to do. But on a routine basis, they're too expensive and too much of a pain to kind of, I think, do every year or something like this.
So do you believe in contracts?
Depends. So I like them at the beginning because, so do I believe in contrast is a question. And so the issue there is at the beginning, it can be helpful to kind of see. So one of the things that we look at to make a diagnosis, the basic principle is you want dissemination in time and space. We talked about space with different parts of the brain. Dissemination in time is to kind of say those events are happening over time. That is that it's a chronic disease. We talked about that one-time disease. Sometimes that can kind of happen. And so if we see on MRI that there's lesions that are active and lesions that are not, so the difference between a bruise versus a scar, then that can kind of tell you that this is happening over time, and it can be helpful for that. If you have new symptoms, sometimes it helps jump out. If you don't have a baseline, somebody's transferring in, moving into our center or something like this, showing up at the emergency room, contrast can be helpful. On a routine basis, I don't think it adds much if you have a good baseline MRI to do that. There's some concern around contrast accumulating in you. It's a very stable molecule. People will have contrast that accumulates, and they can see this on MRIs. And there's some concern that that could be toxic and things like this. I'm not particularly worried about that, and that's not the reason I don't do contrast. It's just mostly because it saves you money and a little bit of time in an IV. So if you don't do contrast, you don't need an IV, you can kind of get in and out 5 to 10 minutes faster. Just to allay fears of contrast, there were trials in the early 80s when we first got MRIs, maybe 90s. So the first MRI, by the way, was 1980. So we have not had MRIs that long, just to put it in context. And people would get 3 times, like triple dose contrast every month for 3 years. So if you add all that up, it's close to about 80 doses of contrast. I know you guys get a lot of MRIs usually, not 80's worth. And I have had patients that were in those trials, and I mean, I can't tell the difference, right? It's only when you look at it specific, like very carefully and stuff like that, can you pick that up. So I think it's a safe compound. If you go to San Francisco Bay, apparently you can pick up contrast material in the ocean. Like it just hangs out, it's just stable, that kind of stuff. So anyway, sorry, to get to progression. So why is my MRI stable, but I'm getting worse? All right, so we talked about bruises and scars and little white spots and how they look like eggs and all this other stuff. That goes with relapses. We talked about sort of shrinkage as we get older, but in MS and that progressive form, what we can associate progression with is kind of this whole brain shrinkage. What's driving that is the process we don't know, which is part of the reason that it's really hard to come up with drugs against that progressive phase of the disease. If we could fix aging, we might be able to fix progression. But so far we haven't done that yet. So that's part of it. When we look at shrinkage, we have very fancy computers that can measure it. and things like this. We talked about measuring sort of the surface of the brain and somebody kind of outlining it and all that kind of stuff. The change in brain volume per year is 0.25% per year. The change in brain volume from when you wake up in the morning to that night, because you're hydrating throughout the day and then get dehydrated overnight, is in the order of like 1%. So you're trying to measure a change over a year that's much less than what your brain shrinks and swells along the course of the day. So if you do MRIs over 10 years, you might be able to see those differences. In clinical trials where you do MRIs on like 500 patients, all that stuff averages out, and then you can kind of see those differences. So we can do that, but literally in clinic, I've seen, you know, percentiles of patients come in and be like 10th percentile, 90th percentile, 20th percentile. It's like random numbers almost. And if you change MRIs, it gets worse because that change can be a lot worse. Our first research scanner, when we switched it soon after I got to campus about 10 years ago, everybody's brain that got scanned on the new scanner went up 2.5%. It's a really expensive way to grow brain, and I'm not sure it grew very well. My other pseudo joke a little bit about size, and size matters, as I do like to point out that men's brains are much larger than women's brains. I am not sure that means much of anything. Okay, and so size is important, but it's a little bit of sort of like how well connected it is, how well you're using it, and all of that other stuff that becomes really important. So it's a little bit, again, just this idea of putting things in context, I think becomes really important, and not fixating on the numbers. And we see this with like lesion numbers. So, you know, I had, there's a guy up in the mountains that had an MRI machine, and you know, some of the patients came down and you would see these MRI reports, and one year it was like, MRI was stable, it had 12 lesions. Next year it was MRI was stable, had 17 lesions. Next year MRI was stable, had 12 lesions. You know, it was just, the numbers were like all over the place, and you looked at it, but it's just how small were you calling a lesion, you know, that kind of stuff that made it really hard. So again, just comparison becomes a lot more important than that.
On the subject of cognitive reserve, we have had a number of questions asking about it, kind of how to keep up brain health, cognition in particular, cognitive issues like poor working memory, can't initiate regular activities, and are there any OTC supplements or any treatments?
Over-the-counter supplements, yeah.
Mm-hmm.
Easy. This one, I got an easy one-word answer for you. It's called wellness. All of it. You got to eat right. You got to have exercise. You got to sleep well. All of those things become really important, right? Active, not just physically, but mentally. A lot of those things. When we talk about those connections and maintaining them and all that kind of stuff, those growth factors in our brain, usually it's the nerve. So this nerve touches to this nerve, as soon as it gets a signal, usually it's putting growth factors to say, hey, yes, this was an important message, you know, let's keep this relationship going. And those growth factors kind of keep a lot of that stuff, where it tells, hey, we need more connections over here, come over here and connect with me. So things like brain-derived growth factor and things like this sometimes get expressed. Exercise, being active, all that kind of stuff is the stuff that helps bring those signals in. If you're weak and you're overweight, that's that much weight that your weak muscles are trying to kind of carry. So trying to be a good weight, trying to avoid the sleep apnea. I mean, these are these spirals, right, that you can kind of go around in circles and kind of keep trying to figure out how you're going to fix them. And it just becomes important to kind of chip away in. To kind of go through the basics, and you might figure out, and it's the same stuff that is good for the heart is good for the brain. So don't smoke. You know, drugs. You know, so from a smoking perspective, this is important, especially with cannabis, right? So I don't care about nicotine. I don't care about THC. I don't care about CBD. I don't care about those compounds, right? it's a little bit kind of like saying like, hey, if you want some aspirin, go out and chew on some willow bark. That's where aspirin got found, right? And so I prefer not to chew on bark. If I can figure out the dose and get it consistently and more pure, right? I avoid all the worms and stuff like this that might be in that bark, and that kind of stuff. So, you know, it's the coal tars, it's all that other junk. So if you're doing cannabis, smoking, like if you're doing a nicotine patch, that's fine. If you're doing oils or gummies for cannabis stuff, that's fine. Trying to avoid the smoke, the vaping, all that stuff just has other chemicals that kind of go with it that increase inflammation and kind of make obesity, recent paper just kind of showing that it increases progression. So trying to kind of be a good weight. You know, we talked about diabetes a little bit, kind of being a comorbidity for COVID. It's also kind of, you know, it adds a lot to MS because it also can kind of lead you to a lot of numbness and tingles and pains and things like this in the legs and peripheral nerve damage associated with it. Low salt is good probably as well. There's some suggestion that is that salt, not so much in blood vessels, but gets into kind of the tissue fluid, that it can kind of increase inflammation. So low salt diet is good. Exercise there helps because it helps you sweat out salt. So it's a good way to kind of get rid of salt if you're sweating. From an exercise perspective, so to go back to diet real quick, there's a lot of stuff that you can really cut out from diets, it turns out. You know, gluten, dairy, all these other things, right? So my only caveat is cut out, but don't cut out too much, right? Like you don't want to look at a plate of food and be like, I'm eating cardboard because of my MS, right? Like you have to enjoy what you're eating and finding ways to do that. And I think it's a little bit limiting if you start cutting out dairy and gluten when you don't have a problem with dairy or gluten. Okay, now if cutting out dairy and gluten helps you kind of keep track and make you eat better foods, and because of that you feel better, go for it. And so it's just trying to find the right balance again for you for that. From an exercise perspective, it's whatever you're going to do. Okay, I use me and my wife as examples. My wife loves to swim. I like to belly flop. I don't know. I get bored. You know, I'm not a runner. You know, I get bored, but I love playing soccer. As long as I'm chasing something or getting chased, I'm all in. She likes to do the row machine. Can't do that, but I'll get on a bike. You know, so trying to figure out again safe exercise, right? If you're getting on a treadmill but you're catching your toes as you're running, don't do that. You know, take something out like a bike or an elliptical or something like this, where you know you like doing it, or you like watching the shows and you know putting it in front of the TV or whatever it is, right? Try and find whatever you like to do that you can do safely. What am I missing from a wellness perspective? Let me think. What am I missing?
Fatigue.
Fatigue.
Fatigue, sometimes MS people stay with exercise and
Yeah.
do as much as you can do.
Yeah, so that's a great question. So the question was around fatigue. This is number one symptom in MS. So if I'm limited by fatigue, you know, what can I do? And I actually like to extend fatigue to everything, right? So in MS, it's fatigable weakness, fatigable numbness. Today I saw a patient that was reporting like, hey, I go for, you know, a 1.5 mile walk, and after a 1.5 mile walk, my right side gets numb. You know, and so it just wears out. The body heats up or whatever it is about it, you know, that body just can't compensate where she can feel, and those nerves stop working for that. It is not uncommon for me to do a quick exam, you know, in the room, and they look awesome, and then they tell me that they can't walk 2 blocks. And that is absolutely the case. It's just they peter out much faster than, you know, most other patients, you know, and so that fatigability to things is definitely a component that we see in MS. And it makes sense when you think about the disease. If you have a job that's being done by 10 nerve cells that really should be done by 10,000 nerve cells, those cells aren't going to last very long. If those nerves have lost the insulation around them that makes those cells be more efficient, they're going to peter out faster. And we do see that those nerves that lose the insulation have a lot more mitochondria. Mitochondria, think about it as sort of like the powerhouse, across the street. So, that's what's powering, giving the energy to the cells. They need much more mitochondria to do that. Well, you don't have that much more sugar to give those cells to do all that stuff. Your blood flow isn't flowing 10 times faster in an MS patient than it is, in somebody who doesn't have this. And so you go through that energy and then and it goes out. So that fatigue component becomes really a big problem. So from an exercise perspective, the goal is to try and spread it out as much as you can. Sometimes it means instead of doing a 30-minute workout, you're doing 3 10-minute workouts throughout the day. Is that feasible or reasonable? That's the challenge, to be able to do that, right? If it takes you 10 minutes to get ready to go to the pool, and often it's more than that, going to the pool 3 times a day for 5 minutes isn't going to be really exciting of an exercise day, right? So, so it's trying to find, again, sort of like what you can do, trying to take those breaks, but getting up every hour, trying to do something, can be really helpful for that. On days where I'm sitting at the computer, you start looking at your measurements and it's like, I broke 1,000 steps, right? Like it's not uncommon to see that, and you just forget about it because you're just out of mind, out of sight. So it's set the timer, and every hour I'm going to get up, right? Or I'm going to try and add in a little bit. And those little bits add up. 3,000 calories is 1 pound. So if you want to think about it that way. And that's kind of what the calorie intake of an average person a day is, about 2,000, 2,500 calories. I can't go a day without eating. Otherwise, I might stand a chance to lose weight, but I don't know. And then on top of that, you have, from a fatigue perspective, the problems that we described with sleep, right? So because of all the symptoms that happen, then you don't sleep as well, and it adds to that fatigue. What can you do? You can, if you can get good sleep, a lot of times that helps reset the energy so that at least in the morning, until it peters out, you have more energy to do things. So it's organizing your day to do some of those things where you're trying to really get them done first thing, and some of the other stuff that maybe doesn't take quite as much energy a little bit later in the day, where you can still kind of get to it. And sometimes it sucks having to plan it to that much detail, but that's kind of what we're left with.
So do you think that mental fatigue and physical fatigue are measured in the same capacity?
Yeah, it's the same fatigability. It's just different parts of kind of which nerves are doing it, but that process affects all of it.
On the subject of movement, can you also talk about suggestions for how to cope with declining balance? This person already does yoga and aerobics, but is still declining.
Yeah, so so kind of like, if I can ask one question that's about fatigue, if I can do one thing on an exam when, for you, so he puts up with me in clinic. So Daryl, when he sees like walk, like from walk, I can tell a lot of different things. So what is balance and what's the issue with balance becomes important. Is it because you're weak? And so if you can't control it, is it coordination, right? I described like the patient that's drunk and kind of opening up their stance and kind of making their legs a little bit wider so that they can kind of balance out a little bit easier. So is it a balance issue? Is it is it a sensation issue? Knowing where my feet are in space. That is a type of, when we think about numbness, there's actually many different types of numbness. You can feel vibration, you can feel touch, sharp pain. And one of the other ones is proprioception. Proprioception is knowing where stuff is in space. So you can do that as a test. I put my thumb here and I go reach it. I'm pretty good and I can kind of go get it, right? If I can do it on the other side, I know where that's at and I can go reach it. If you're sitting there with your eyes closed and you have somebody wiggle your toes up or down, I know if you're going up or down, only because of proprioception. So if you don't have it and you're walking, I have no idea where that foot is. And so from a sensation perspective, then that can become an issue. How you balance those things, you have to know what the problem is, and then you can kind of attack it. So if it's a proprioception issue, you can look at your feet. Now I know where they're at in space, and I can kind of go and make sure that I'm not stepping on a rock or something else like that as I go through. If it's strength training becomes important. Is if it's a balance, true balance, like coordination issue, then that's where you can kind of work on coordination exercises. From a coordination perspective, yoga is awesome, Pilates, and then just a lot of little simple exercises at home. The sobriety test. If you can't do the sobriety test, and I'm not sure the camera's seeing my feet, but you guys can, you can do the sobriety test. And as you get better, you can bring your feet closer and closer together. Do it in the hallway so you can kind of bounce off the walls as needed. And you can put, if you have linoleum or a line, or you put like masking tape or painter's tape or something like this on it, you can kind of walk on that to kind of practice that. You can stand on one leg. You make it really hard and close your eyes. If you're doing some of that stuff with the eyes closed, try and do it like in a closet-ish, a corner, something like this, where you can kind of bounce off the walls pretty easily if you start getting off balance. Again, safety first for all these exercises, but doing those exercises 2-3 times, even if it's just for a few minutes, can kind of really help with those balance things. We had one question. Sorry. No, go for it.
One other exercise question. And some courses, they have you in lieu of a lot of reps do very few, and some of the old people, it's just like do 3 reps.
Yeah.
But load it up. Does that, I mean, when you're, it's engaging more muscle, doing
Yeah.
more strain, but it's not so many nerve firings, or yes or no?
I think with exercise, the trick for a lot of this stuff is mixing it up. So you're not doing the same thing all over the place. And I think that's kind of just, to put it in today's cool lingo, right, is cross train. So you kind of mix it up a little bit, right? You got fast twitch muscles and, slow twitch muscles and things like this. You want to kind of exercise all of them as much as possible. 2 seconds, if allowed. The one thing we didn't get into a little bit that I kind of, just I think interesting to kind of realize, I don't think we're using aids as much as maybe we did in the past, or thinking about it, but with balance, it becomes really important to kind of recognize it. And that's like, hey, if all it takes is just to get a little bit wider, a cane might be really helpful. If you're really needing extra help, 2 canes, 2 walking poles, if you prefer to call them that, a walker, whatever it takes. If you're petering out, a seated walker so you can kind of sit down. If you're falling still with that, not doing that, if it's starting to prevent you, it's like, hey, I would love to go to Walmart, but I can't, just because I peter out, a wheelchair, scooters, you want to keep trying to do stuff because cognitively that becomes important. And then things like electric stimulators, so muscle stimulators like the Psionic NeuroSleep, the nerve stimulators like BioNess or WalkAid or things like this. So those are important things to think about if you got foot drop and AFO and that kind of stuff as well. So just stuff to kind of talk about to your provider.
What if the problem is falling backwards?
Falling backwards?
Yes. So
sometimes that's a little bit of a position aspect, and it's a little bit of knowing where you are in space. Sometimes when you backwards is a little bit less common than falling forward, and oftentimes you'll see patients on a walker that are like this, and it's a little bit because they're trying to balance things out. But to me, it would suggest that it's a little bit of not knowing where things are in space and trying to coordinate that. I'm not an expert on this, but that would be kind of the things I would think about when you're working with PT. And with working with PT, PTs are very comfortable sometimes with working with weakness, rehabbing knees and hips and all this other stuff, right? Your neuro PTs are going to be a little bit more familiar with balance stuff. And so if you're trying to kind of work on balance stuff, finding the right PTs can be really helpful from that. And a lot of them do have that training. It's just some of them don't do it a lot.
That's a huge issue for my mother is, so there's like this weird cycle that I realized that like initially when she was falling a lot, it was like, well, just sit down, don't get up. right? Well, slowly we realized, wow, if you just sit down, you might as well just get the wheelchair and stay in there. And so it became that balance, but it is a very dangerous kind of tightrope walk she does because it's so variable. And she has gone to PT, not a neuro PT, so maybe that's something she
Maybe
needs
something to
to
think about.
try. But what do you have to say about that risk assessment with balance? Because even talking to the VT, it's like, it is just not clear. It's like, it's clear as mud
Yeah.
when it comes to day-to-day, what do you actually do?
Yeah, so I mean, you do
day-to-day?
get to a point sometimes where cognitively too, it gets hard to kind of work with the PTs or remembering to do certain things, right? If it's trying to find that center of balance so that you have a good posture can be important. The problem is we tend to fall back on habits a lot of times. And so it has to be stuff that you kind of reinforce frequently to kind of help with that. But that's exactly right? So we see these tipping points, and at some point you kind of say, like, I'm more worried about you breaking a hip than I am about you getting exercise at this point. I try to encourage that as much as possible. It's part of the reason why I like to see people working, even if it's part-time or other things like this, because it forces you to do PT, get dressed, walk, OT, think about stuff, so speech therapy on the cognition piece and that kind of stuff, right? And so continuing to do those sessions and thinking about it, is it, an issue where, like, if you're attached to a walker, is it a sturdier walker so that, like, that way, if you're going to fall, you're going to have to not take this whole walker with you, that kind of stuff. And so finding those ways to kind of let you do that stuff.
We're going to have one more question, and then I'm going to share a bunch of resources, but we are very near on time.
I'm curious, what caused you, or why did you choose to focus your career on MS?
Yeah, I fell into MS. I wish I was a little bit more planned about it. I was a gene jockey. I'm an old bio guy, molecular biology. I love tinkering in the lab with moving genes around and that kind of stuff. When I came to the PhD program, the gene cell therapy lab that was in here was in the neuroscience program. So I said, all right, I'll join the neuroscience program so I can be part of that lab. They were doing cell therapy stuff where they put in dopamine cells in Parkinson's patients, like neuroscience. And then when I was starting to do neurology back up again and starting to kind of hated neurology, by the way, in medical school. Like I took it off the list. There was no way. I left it to the very end because of the neuroscience piece. I thought I'd become a psychiatrist or maybe a neurosurgeon. Had much more interest in that stuff. Did it, hated it, did neurology and ended up falling in love with it. I don't like the neuroanatomy piece, like this nerve connects to that toe, this kind of stuff, and it goes through all the stuff. I felt like I was memorizing an atlas. But it was, for some reason, the immune pathways made a lot more sense, and it kind of went back to my molecular biology. So I got rid of the neuroanatomy, and my neuroanatomy became very easy. It's close to the surface. It's just inside of the brain. No. Of all curious and interesting pieces, then my wife's grandfather actually has MS, and I never met him, but it became much more tied in with some of those other things. But yeah, no tie specifically with it. Yeah.
Is there a quick answer to, should we take alpha lipoic acid?
It's cheap and it's easy. I don't see a problem with it. On the other hand, save it up and go out for a nice steak dinner. I don't, sorry, vegan meal. What's the more appropriate answer these days? I don't know. An awesome meal.
Thank you guys all for being here. Thank you for the many, many wonderful questions. This format, this event, Conversations, I think is a wonderful chance to get a small soundbite on a ton of different topics. But I wanted to make sure that you guys are aware we do have a lot of more in-depth resources on many of the topics that were touched today. So you might get 30 seconds to 3 minutes here. Ed Summit presentations are 20 to 30 minutes, webinars are an hour. And so the doctors have an opportunity to go into a lot more detail and just some of the topics that we talked about tonight that we already have resources on. And I would be happy to email a direct link to these. My email address is education@mscenter.org. So you can email me anytime and I will send you direct links to these things. We have a full webinar on cognition with a neuropsychologist. We also have a presentation from Dr. Shah on cognition, which covers a lot of sleep and sleep apnea questions. Dr. Shah has also done a webinar on family planning. We have many, many articles in our Informs magazine covering all of those wellness topics. We have a diet issue, we have an exercise issue, we have a fatigue issue. We've worked with several great physical therapists throughout the years, so we have a lot of presentations from them on mobility and fatigability and balance. The discontinuation studies that Dr. Corboy did, he did a very long, hour-and-a-half long webinar all about the study results. We've done multiple articles publishing and going into those results. Coming up, we have the Education Summit, which I know BTK inhibitors will be discussed, as well as stem cells. And then we also have that webinar with Dr. Molman on genetics and environmental factors leading to MS. So that was a ton of resources. Like I said, my email address is just education@mscenter.org. Let me know what you're interested in. I'll send you what we have, or if we don't have it, maybe that'll be the next topic of our next webinar. So thank you guys again for being here. Thank you for being online, and we'll look for you at the next one.